I see people popping in and joining us. Thank you for being prompt. I am sure that we will have more folks popping in as we go, but it is 2 o'clock, so I think we should get rolling. I want to thank everyone who is on already today. My name is Matt Shepard. I'll be hosting and handling some of the background stuff. Thank you also to our scheduled presenters, which will include Center for Medicare Advocacy Managing Policy Attorney Kata Cortez, Senior Policy Attorney Toby Edelman, Litigation Director Alice Bears, and we'll have an intro from Co-Director Scott Perkins. Before I hand it over to Scott to get us started, let me take my usual moment to do some explaining about the system we're using today, which should be a little easier than usual because we are finally moving to Zoom. Just like in any Zoom meeting, you can change your audio settings using the little microphone or possibly a headset icon down at the lower left on the control panel at the bottom of your screen. Also on that panel is the traditional chat option. We welcome you all to join us in the chat. Let us know who's on, what organization you're with, where you're from, or anything else you'd like to share. In addition to the chat, just like on our old webinar system, there's a Q&A option. If you think of a question or comment, you don't want to have to remember it, you can throw it right in that Q&A panel at any time, and we'll pass that along to our various presenters as appropriate. Next to that, you can turn captions on and off should you need those. And finally, there's the ever-present and all-important little hand that you can use to raise your hand if you want to ask or discuss something aloud. We will, as noted, stop after each topic section to see if we have any questions, comments, or discussion. Finally, everyone should have received a copy of today's issue brief at the email address you used to register. But if for some reason those didn't make it, we will throw that link up in the chat as well. With that, I'll bring up Scott Perkins to say a few words to get us started for this call.
Thank you, Matt. Welcome, everyone. As Matt noted, for those of you who have not met me, my name is Scott Perkins, and I'm the center's co-director, along with my dear colleague, David Lipschitz, who I am quite sure all of you know very well. David is traveling today and unable to make it to this meeting. So since this is the first meeting we've had since the election, we wanted to just take a moment and say a few words in that context. First of all, I want to say thank you for all of you for joining us today, and more importantly, for being partners in our work to ensure a strong Medicare program that meets the needs of all beneficiaries. Back in October, we knew there'd be work to do after the election. Today, we know that much of that work will be defensive. We will be working with individuals like you and the organizations that you represent to defend against legislation and policies that would harm beneficiaries and weaken the traditional Medicare program. Congress and the executive branch are about to change. What isn't changing includes the center's mission to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities. And as always, we will do that work on a bipartisan basis, collaborating with all of those who share a commitment to acting on the issues that matter most to beneficiaries and to the traditional Medicare program. There will be plenty of work ahead, and so we are very grateful to all of you for your partnership and collaboration. I hope we can all continue to support each other, amplify each other's messages, share information, and perhaps most importantly, share our hope, humor, and inspiration in the coming years. The work ahead is choiceless. Doing it together is the choice that we can make. So thank you all for being here, choosing to work with us on this. And now I will turn things over to our managing policy attorney, Kata Cortez.
Thank you, Scott. I think we all needed that inspiration and look forward to continuing to work with everyone. Just a quick agenda update for everyone. We have the welcome from Scott, and then I will discuss the oral health part of the physician fee schedule final rule that came out this month. Then I will transition to discussing MA and open enrollment with a specific warning about flex cards. Then we'll turn it over to Allie Bears for the litigation update, and then to Toby Edelman for the skilled nursing facility update. We'll do Q&A after each section to give everyone an opportunity to raise issues and have a discussion before we go into each topic, but then again at the end of the presentations. So I will discuss the physician fee schedule and oral health. If Jeff, you could please move to the next slide. Thank you. So this month, the Centers for Medicare and Medicaid Services issued a final rule that announced policy changes for Medicare payments under the physician fee schedule and other Medicare Part B issues. The rule includes an important clarification to reimbursement for dental services necessary to the clinical success of certain covered medical treatments. This builds on the clarification in the 2023 and 2024 physician fee schedule final rules that recognized payment for dental services that are essential for certain covered medical services. This final rule includes into the new clinical scenarios, dental or oral examination in the inpatient or outpatient setting prior to or contemporaneously with Medicare covered dialysis services for the treatment of end-stage renal disease, and also medically necessary diagnostic and treatment services to eliminate an oral or dental infection prior to or contemporaneously with Medicare covered dialysis services for the treatment of end-stage renal disease. We're very pleased with this additional clarification. We have put out statements supporting it. We're part of the consortium for medically necessary oral health coverage. We also released a statement with that group of over 240 other coalition members also supporting this change. And so we're very hopeful that this will expand a little bit of oral health coverage to certainly deserving vulnerable population. And with this addition, we have several groups, and it's listed on this slide, of folks who will have dental coverage for specific conditions. Hopefully these stay after the new administration. We don't know who will be in charge of CMS. We don't know who will be in charge of Medicare. Because this was released this month, it does fall within the Congressional Review Act timeframe, which is 60 days, legislative days from when Congress adjourns. So we don't have an exact date because we don't know when they will adjourn, but likely will be in May. So anything that was published after a May date will likely be within that window. So this could be vulnerable to that overturning from Congress, but we will keep you all posted on that if it does end up being considered for being overturned. So I will open up for questions about this and then move on to the enrollment period and MA and flex cards if there are no questions here. So if there are any questions, please feel free to ask.
We had one question from Mark Wormer-Skirchin, but it's more for David. It's kind of specific to network, so we'll have to tackle that one offline, Mark. Thank you. Charlie, familiar face. Do you have something to ask?
Yeah, thank you. The problem I see more often about dental coverage is dental deterioration problems that occur after radiation treatment for tongue, neck, or throat cancer that happens after the treatment period. Yet the person's doctor says they're clearly linked to the treatment. But as I understand this rule, it doesn't cover problems that occur post-treatment. Am I correct on that?
Yes, I believe that is correct. It is quite limited, but it is a small improvement to what we have had in the past. But yes, I believe that is accurate.
I mean, how close in time does contemporaneous mean? Is the other question.
Yeah, I think that we're still working through those kinks. We haven't seen a whole lot of coverage actually happening. We've been working with CMS on this we'll see how well that collaboration continues in the next administration. But yes, we have not seen too much of this actually being covered for individuals, though it is in the reg now. But yeah, it has been a challenge to actually have this see uptake of this.
Well, we appreciate your continuing work on it.
Thank you.
Thanks, Charlie.
Lots of folks on the call who also have been working for this for many years. So thanks to all of you for your efforts as well.
Call out Dr. Lynn Mountain, who's on the call.
Absolutely.
I think that's it for that topic. Kanta, if you want to go ahead.
Okay, Jeff, if you could turn to the next slide, please. So as you all know, open enrollment is still going on until December 7th. Recently, we'd seen a lot of media coverage of the challenges with MA and also interest in Congress to raise concerns about MA, to explore reining in overpayments and MA oversight. This is a topic that was really gaining a lot of attention, and we suspect that that may slow down with a more pro-industry Congress coming in and with the change in administration. We will continue to work on the consumer protections that we have been working on for many years, that we work on in other administrations that have also been more industry friendly. So that will continue. As Scott mentioned, we'll probably expect to shift our focus to include more defensive work as well, though. But we call on all of you to help us and work together to amplify any of these MA stories that you're hearing, any obstacles to care, so that we can continue this momentum that we really had been seeing in recent months and years to try to rein in MA. We have an alert that's included in the slide about some of these changes that had been coming up recently with more oversight and with more interest. We also have a slide, we also have a link on the slide to our open enrollment webinar that we did last month, if anyone has any questions about open enrollment. One thing that I just wanted to flag today is the flex card issue. At the center, we've been working on this issue for the last few months after we learned of Connecticut residents whose subsidized rents will increase due to money that's preloaded on the flex cards that they received through their MA plans. These were duals who also received federal assistance for housing through HUD. And apparently, because their cards can be used for certain utilities, such as electric, internet, and cable bills, and are not just limited to food and over-the-counter medical expenses, also didn't matter if the cards were used. The amount on the flex cards was counted toward their income or assets for determining eligibility and the amount of benefits that they could receive. Obviously, an unintended consequence, something that we thought we could quickly get a resolution to, have the White House encourage guidance. There's no industry pushback on this, so we thought this would be, kind of a simple ask. It's turned out to not be such a simple request. We were hoping to have this guidance out saying that the flex cards cannot be counted as income for eligibility and amount determinations for any kind of public benefits. We hoped it would come out during the enrollment period so that people would be aware of it and could understand how the flex card would work and make more informed decisions. However, that hasn't happened. So we've shifted our focus now to raising the alarm about this and issuing warnings so that people know when they are enrolling in a plan with a flex card that this is a possibility. It seems to vary and not be completely straightforward. We can't definitively say, yes, it will be counted toward your benefit, but it's a possibility. And so people should be aware of it. And those helping people enroll should also be aware that it is a possibility. We continue to advocate for guidance that says that it doesn't count while also raising this warning. If anyone would like to join our advocacy group, we have many of you on the call I think are already involved, but if anyone else would like to join, please let us know. We're always looking for additional advocates who can help spread the word on this. If you've also seen this in your state and would like to let us know, please do so. We're in constant contact with different agencies and trying to let them know that this is happening. So if there are any questions about that, please let me know. We have some links in the slide and in the issue brief to some of our alerts and some congressional letters urging guidance as well. So some more information if anyone needs a little more detail. But I'll take any questions if there are any.
Right, thanks, Kata. I don't see hands raised at the moment. We had a follow-up question from Mark related to his question about networks and droppage. So we'll tackle that one again offline. I think we can move on.
Okay, well, if any questions come up on either of these topics, please feel free to share them in the chat or at the end of the presentation when we have another Q&A. But for now, I will turn things over to Allie Bears for our litigation update.
Welcome, Allie.
Great. Thank you, Kata. I apologize in advance for my voice as I am fighting off something here. But I'm going to focus on this call on the long-awaited observation status appeals regulations, which have come out. For the other matters that are listed on this slide, I will refer you to the litigation section of the brief that you received for updates on these other matters that are listed here. So could we go to the next slide, please? Okay, so if you've worked on Medicare issues over the years, you're probably familiar with observation status and the problems that it can cause to people who are hospitalized. Observation services are given to patients who are considered outpatients, even though they're very often on a regular hospital floor. You wouldn't know that they're not inpatients. And the real problem can happen if the patient requires nursing facility care after a hospitalization, because that requires a 3-day inpatient stay for Medicare coverage. And time spent in observation status does not count towards that 3-day stay. So you get this 1 + 2 does not equal 3 problem. You can be in the hospital for longer than 3 days. There's also a problem for people who may only have Part A of Medicare. It's a small percentage-wise, but there are a good number of people out there who have Part A of Medicare, but not Part B. They may think, oh, I'm covered for hospitals because Part A is called hospital coverage. But then they go to the hospital, and if they are put on observation status, which is covered by Part B, they wind up with no coverage of their hospital at all and may have to pay the full hospital sticker price for their hospital stay. And Medicare has not allowed patients to appeal the issue of whether they are properly categorized as inpatient or as outpatients receiving observation services. Many people have had to forego care or pay thousands of dollars out of pocket. And that's particularly for that nursing facility coverage that they may need after a hospitalization. And there was no way to appeal it. So we at the center, along with co-counsel Justice and Aging and our pro bono partner, Wilson, Sonsini, Goodrich, and Rosati, litigated a class action which won the right to appeal the observation status classification in certain circumstances. The citation for the case is on the top of that slide. And can we go to the next slide, please? Thanks. So the case has a long procedural history, as you can see in that first bullet point. We did have a bench trial in 2019. The judge published a long decision in 2020. The government appealed that decision, and it was affirmed in full by the Second Circuit in 2022. Then it took the government a while to figure out whether it would seek cert from the Supreme Court. So I think it was sometime in late 2022 that decision was finally final. The holding of the court was that Medicare violates the constitutional rights, specifically the due process rights of class members, by not allowing them to appeal their placement and observation status. Now, the court did narrow the class from what the plaintiffs requested. So in the end, it is a subset of the affected group who can appeal. The main limitation being that the class is limited to people who are admitted as hospital inpatients and then reclassified by the hospital as outpatients receiving observation services. So why, you may ask, did the court limit the class this way? For those of you who took constitutional law and may remember due process doctrine, there is a requirement of state or government action for a decision to be protected by due process. And the court found that state action is limited to those reclassifications when the hospital staff is essentially conforming the patient's status to standards dictated by Medicare. It did not find state action when a physician is deciding the status of a patient. So there was a tremendous amount of argument, evidence, and briefing on this topic, but this was the way the court came out. So what we have is a subset of people affected by the issue who have appeal rights. Not as large a group as possible, but of course, very important for those who do fall in the class definition and can appeal. Excuse me. Beyond that limitation, there are two basic groups in the class. There are the people with what I think of as the nursing home problem, defined as people who stayed in the hospital at least 3 days, but were inpatients for fewer than 3 days.
Allie, it looks like you are muted accidentally.
Sorry
There we
about
go.
that.
Yep.
Okay. So I was talking about the two groups of people in the class. That's people who have what I think of as the nursing home problem, people who stayed in the hospital for at least 3 days, but were inpatients for fewer than 3 days, and people who have the no Part B problem, people who simply were not enrolled in Part B at the time of their hospitalization. And the court ordered Medicare to create appeals processes for all class members dating back to January 1st, 2009 and going forward indefinitely. So as you'll see, some folks will be able to appeal retroactively, and going forward, some will be able to make use of prospective appeals. Can we go to the next slide, please? Okay. So then we moved on to implementation, and this was done by notice and comment rulemaking, which can take a while. Giving you the short version because it took a lot of prodding, and the court actually had to impose some deadlines, which it did not do at first. We finally got a proposed rule at the very end of last year. And then we and many others submitted comments. We thank the many advocates who signed on to the comment letters that were submitted. And the agency did listen and respond to some of the comments. So thank you again for everyone who supported that effort. And then on October 15th of this year, we got the final rule with the new regulations. The link to that final rule is on this slide. And as I mentioned, the regulations create two types of appeals. Just sort of my overview here, as I will say, the court emphasized that these appeals should be substantially similar to existing appeals in Medicare. That was kind of a theme throughout the litigation and throughout the decision of the case. So I would say that the good news is that these processes are substantially similar to existing Medicare appeals, and the bad news is that these processes are substantially similar to existing Medicare appeals. And I'll just review these. For those of you who are familiar with Medicare appeals, they're there, they can be used, and they have their issues, and it's just a matter of sort of getting through them. For retrospective appeals, for class members who did not have a process available at the time their rights were violated, this is mostly going to be for people who had to pay out of pocket for skilled nursing facilities, for skilled nursing facility services. And if they succeed in these appeals, they may be able to obtain a refund for those out-of-pocket nursing facility costs. There will also likely be a small number of people who did not have Part B who can obtain refunds of their hospital costs. These appeals will cover a closed period and will be available for a closed period of time. They will cover hospitalizations, as I mentioned, dating back to January 1st, 2009, and up to an implementation date. What is the implementation date? We don't know yet. In the final rule, Medicare said it will announce that date on medicare.gov and or cms.gov. I checked about an hour ago. It hasn't been announced yet. So we are watching for that implementation date. Prospective appeals are for class members who are in the hospital and want to appeal their reclassification from inpatient to observation. This will be most useful for people who require skilled nursing facility care after a hospitalization, but don't have the 3-day qualifying inpatient stay. If they succeed, they'll be able to gain Medicare coverage of the skilled nursing facility stay and not have to go without care or spend thousands of dollars. These are supposed to, their target date is mid-February for that when these will become available. And there is a new notice that will be issued by hospitals for people who are eligible to appeal. And there are actually 2 different timeframes, which I will review. Next slide, please. This slide reviews I'm sorry, I just lost my place here. Okay, so this slide reviews the retrospective appeals. Who can appeal, when, and how? And I've paraphrased who is an eligible class member. For when, under the final rule, people will have 365 days from whenever that not yet announced implementation date is to submit an appeal. And there will also be good cause reasons allowed for filing, for late filing under the usual good cause regulation for Medicare appeals. Medicare will be using an eligibility contractor to kind of make a pre-appeal initial determination about whether the person is actually in the class and eligible to appeal. And they're going to be posting a standardized form with instructions on how to submit a request. It's going to be available on their website or by calling 1-800-Medicare. We will, of course, post it as soon as it's available. If that contractor finds that the person is eligible, the decision will be forwarded to the relevant Medicare contractor to perform the substantive appeal, and then it will just go forward like a regular Medicare appeal. Next slide, please. And then with the appeals not starting for a while, what can people do who think they are in this, class that might be able to do a retrospective appeal? This is what we've been recommending for a while, is to gather and keep the records that you're going to want to submit. And I've listed on the slide what are the most likely records. The final rule, I just also want to point out, is very clear. The agency acknowledges there can be challenges in getting access to older medical records, and that the eligibility contractor must work with beneficiaries, providers, and Medicare contractors whenever necessary to help obtain information. And who can help? Well, this is one way in which these appeals are different from standard Medicare appeals. Providers cannot be parties to these appeals. They cannot represent beneficiaries, but they can assist, they can provide information, and otherwise the existing Medicare rules about appointed representatives, authorized representatives will apply. We're expecting outreach and education from Medicare on this. We will, of course, be doing that as well, and we are expecting to do a webinar on December 17th, 2024 with more detail and hopefully more resources and information at that point. Next slide, please. This slide reviews who will be able to appeal prospectively. The agency actually did expand the group required by the court. People in the hospital who are reclassified as observation and either have been there 3 days, but not 3 days as an inpatient, or who do not have Medicare Part B. The expedited time frame for these should be very useful for people who need the immediate decision of whether they have the qualifying 3 days, 3-day stay, so they can go to a nursing facility with Medicare coverage. And then kind of a surprise, because this was not required by the court, there's also going to be a standard, or what the rule calls untimely appeal timeframe. So if the person misses the expedited deadline, which is appealing before you're released from the hospital, you can still appeal at any time. There is no deadline after you have left the hospital and still get a quick decision. Again, that should be very useful. We do get appeals and calls from people who are already in a nursing facility and on the hook financially, or maybe they realize it later. This will allow them to get a qualifying hospital stay potentially after the fact, something that was not allowed before. Structurally, these prospective appeals are similar to existing hospital discharge appeals, if you're familiar with those. The appeals will be to Medicare QIO contractors, and there is an expedited reconsideration level. Then you can go into the standard appeal process with an ALJ hearing and up through the regular appeals process. This process also has a brand new notice, the Medicare change of status notice. There's a link to it on the slide. There's also a link to it from the final rule. The rule explains that this notice was made based on the important message from Medicare notice that's given to all Medicare beneficiaries and hospitals. And here's where I really have to thank my co-counsel, particularly Wei Wei Kwok, who submitted comments on the proposed form that the agency took into account and issued a vastly improved final form that's much easier to understand than the one that was initially proposed. Next slide, please. This is just some further information about prospective appeals, similar to retrospective and the retrospective and to the current discharge appeals. Providers can't be parties, but they can assist. And also, unlike the current hospital discharge appeals, these will not have liability protections. If you're familiar with the current hospital discharge appeals, you get a little bit of liability protection during the time that you're appealing your discharge. That does not exist for these appeals. However, the regulations do instruct hospitals not to bill patients until any expedited appeals are on this issue are complete. So I'll just conclude by saying this is a quite general overview. We are still learning this new process as well. As I mentioned, we're planning a webinar for December 17th at 3 p.m. Eastern. So hold that time and watch your email for registration for that webinar, when we can go into more detail, offer more resources, and hopefully have some information from Medicare, like that implementation date and the form for retrospective appeals. The agency has said in status reports to the court that it expects the retrospective appeals to become operational basically in January. We'll see if that holds, January 2025, and mid-February for the prospective appeals. So of course, we'll be watching that carefully, and we'll be providing as much information as we can. I can take a few questions before I turn it over to Toby.
All right. We'll pull you up here for a couple questions. We have a couple typed in. Please feel free to raise hands if you want to ask something in person. So to clarify, asks anonymous attendee, there is no appeal option for people initially classified as on observation.
That's correct. If you're on observation the entire time, you are not in this class. There is not an appeal right. That's correct. I should mention, we also, this is one of the reasons we are still working on comprehensive observation reform at the center. It's something that my colleague Toby Edelman, who'll be speaking next, is still working on. We still understand that there are still people who are going to be harmed by observation status, and we're still working on comprehensive observation reform as well.
And that was the follow-up to that question. Is there any hope that that situation will change?
Yeah, so we're still working on comprehensive reform, but in the meantime, for the class in this case, there is this appeal right.
One of our attendees notes that you can argue in real time, though, about admitting the patient.
That's another thing you can try, yes.
Marcelo asks, if one appeals at the time, I imagine that means in the hospital.
Yes.
Would the QIO have necessary records?
Yes, they are supposed to, it's similar to a discharge appeal. When that process is started, the QIO requests from the hospital the relevant records, and the hospital is required to provide those records. So records are sort of, in a way, less of an issue on those prospective appeals. They should all be there, and the hospital is required to provide them. The beneficiary does, they are required, like in discharge appeals, to solicit the views of the beneficiary, and the beneficiary can submit additional information. And if there's a supportive doctor there who says, I think that my initial admission of you as an inpatient was correct, and you want to submit something from that doctor, we would definitely say go ahead and do that as well.
Thank you. Olga has a kind of follow-up for that question. She says she is new to advocacy, and this may be tangential, but her experience with the QIO is they are not careful in their reviews, her words. Is that common?
Yes, well, remember what I said about good news and bad news. You know, the QIO, we sort of, you know, we have the contractors that we have, and the QIOs are the most appropriate for these appeals because they're the ones that do expedited appeals already. They also already do appeals that providers do regarding the appropriateness of inpatient admissions. So they have experience both with expedited appeals in the discharge context and with the particular issue that is going to be decided in these appeals. We hope that will help in this situation. You know, all we can do is keep an eye on it and, you know, also encourage people to, you know, keep on appealing up through the levels if they don't get a satisfactory answer from the QIOs.
All right, thank you very much. I think that wraps up our questions for now. So we'll pull Toby up and put the slides back up if we can. And
just
say
wanna
thank
say
you, Ally,
something.
and we'll see you at the end.
I want to say something about observation. The final rule in the preamble says nearly 600,000 beneficiaries receive the MOON, the Medicare Outpatient Observation Notice, which they get if they're outpatients for 24 hours. So there are a lot of people that are still suffering from observation services. We have a very large and sort of comprehensive coalition working on legislation. And it's the nursing home trade associations, all kinds of nursing organizations, medical associations, advocacy organizations. And we have a meeting tomorrow with Mr. Courtney, the chief sponsor from Connecticut. He's sort of fascinating. He likes to meet with us directly and to get the troops riled up. So we will be talking tomorrow about what to do, whether he should reintroduce the legislation as it has been for the last 10 years or so, to include all time in the hospital towards a 3-day inpatient stay, whether it's inpatient or outpatient. So we may have more news about that going forward. But this litigation is a tremendous victory for a lot of people who are really going to benefit. So we're quite thrilled about it. So what I want to talk about in my few minutes is two things: provider litigation challenging the nurse staffing rule and the nursing home reform law of 1987. In April of this year, CMS, for the first time ever, published a final rule creating staffing ratios for nursing homes. The ratios were lower than we wanted. It was 3.48 hours per resident day, so 3.48 HPRD, far lower than the 2001 CMS report, which called for 4.1 hours per resident day. The current rule, the 3.48, is 0.55 registered nurse, 2.45 hours per resident day of nurse aid time, and the remaining 0.48 hours up to the facility, RN, LPN, or aid time. The final rule also requires registered nurses 24 hours, 7 days a week to provide care for residents. There's an exceptions process that allows facilities to have lower staffing levels if they can't meet the standards. And there's delayed implementation, 3 to 5 years, depending upon whether the facility is rural or non-rural. Despite the lower numbers than anyone expected, the exceptions process, and the delayed implementation, the nursing home industry has been relentless in its opposition. Filed 3 cases. It filed 2 cases in Texas, both in the district where there's a single judge who has ruled against the Biden administration in a number of cases. The first case was filed in May by the American Healthcare Association, the for-profit trade association, its state affiliate in Texas, 3 Texas nursing homes, and later Leading Age, the nonprofit trade association. In August, the state of Texas filed a lawsuit in its own name. These 2 cases, filed in the same district, have been consolidated. And at present, there are cross motions for summary judgment, which are being briefed and are pending now. There will be an amicus written primarily by AARP, and we're part of that, which will be filed this Friday, November 22nd. Another case is filed in Iowa. That was filed in October by 20 Republican attorneys general, 17 state affiliates of Leading Age, representing 21 states, and 2 Kansas nursing homes. A motion for preliminary injunction is pending and will be argued on December 6th. If there are summary judgment motions, we will file an amicus brief in that case as well, and I'm currently writing one. The cases generally make the same legal and factual arguments that the nursing home industry has made throughout the regulatory process. This is an unfunded mandate. There's no one to hire. Facilities will close if they have to meet these staffing standards, and residents will be displaced. The way ACA describes it in their case, they said, quote, "That rule exceeds CMS's statutory authority, affects a baffling and unexplained departure from the agency's longstanding position, and creates impossible to meet standards that will harm thousands of nursing homes and the vulnerable Americans they serve." There's a little bit of irony in this litigation. While the cases challenge all parts of the final rule, both American Healthcare Association and Leading Age in 2021 jointly proposed their own Care for Our Seniors Act, which called for 24/7 registered nurse coverage. They seemed to think then that that was permissible. In light of the election, of course, it seems inevitable that the staffing rule will be gone, either through litigation, this litigation I've just mentioned, or legislation that's pending in Congress, or action by the new administration. The administration may need to do rulemaking to get rid of the final rule in any event. That's what happened when the Obama administration had a rule prohibiting pre-dispute mandatory arbitration in nursing home admissions agreements. The industry challenged that provision, got an injunction prohibiting its implementation, and the Obama administration did not implement it. Nevertheless, the Trump administration, in its first time, did have to do rulemaking to get rid of that, to change the rule about arbitration agreements. When the incoming administration eliminates the staffing rule, of course, it will be responsible for the consequences of inadequate staffing. Now, I just want to talk a little bit about the nursing home reform law, which was passed by Congress in 1987 to give us a little bit of hope about keeping nursing home rules. On January 21st, 1981, the first order of business for the Reagan administration at what was then called HCFA and is now CMS was withdrawing a Carter administration rule to elevate residents' rights to a condition of participation. First thing they did, first day of the new term, of the new administration. When the administration's plans to eliminate residents' rights entirely became public, the proposal was withdrawn. Then the Reagan administration proposed making changes to survey and certification, such as conducting less than annual surveys and giving deemed status to facilities that were accredited. Congress responded with 2 moratoria on deregulation and then required a study by the Institute of Medicine. And no deregulation could occur until that report came out. The Institute of Medicine finally issued its report in March 1986, and it became a large part of the legislative history of the nursing home reform law, which was signed by President Reagan on December 27th, 1987, as part of the Omnibus Budget Reconciliation Act of 1987. In retrospect, I think we understand we had a lot going for us. There were federal staff who sent advocates leaked drafts of proposed changes to nursing home rules. We had New York Times reporter Robert Pear, who was extraordinarily knowledgeable about nursing homes and wrote regularly about nursing home issues. We had support from the nursing home industry, which participated in the Campaign for Quality Care that was organized by what was then NICNR, now Consumer Voice, to see which parts of the Institute of Medicine report we thought should be implemented. We had actor Kirk Douglas acting as honorary chair of the Campaign for Quality Care, and we had a very different Congress where Democrats and Republicans alike criticized the deregulation of the nursing home industry. The Center for Medicare Advocacy is planning a webinar on the history of the reform law for early 2025 to talk about how we got from deregulation to the 1987 reform law in detail. Thank you. Happy to answer any questions if anybody has any.
Lady, give folks a second here before we.
I have a
Move
question
on.
for Toby. This is Kata. I'm wondering about when the nursing home staffing reg came out and whether it is subject to potential CRA.
It came out in
vulnerability.
April.
Okay, so probably
So
would be
it's
fine.
Too old, yeah.
Yeah.
It's but there's a lot of well, there was a CRA, but it never got called up. It was proposed, but it's never been called up. But there is legislation to, to reject that regulation. So they've got every possible avenue, the CRA, regular legislation, and all of this litigation.
Yep. Thank you, Ally. If we could have all of our various panelists pop back up here. We can open things up for Q&A here at the end in general, if there was anything we didn't get to.
Well, I'd also say that if anybody has anything that they're seeing in open enrollment that they'd like to discuss, or any other threats that they have heard might be coming soon in Congress or the administration that they'd like to discuss, we really hope to, foster these discussions and continue them as we respond to these, potential cuts.
Question from Mark for the panel. Medicare Advantage is referring to the Wall Street Journal article from last week, which flat out said sickest patients are fleeing private Medicare Advantage plans, costing taxpayers millions. Suggested that the patients in the last year of their life are switching back to traditional, implying they're getting it implied they're getting Medicare supplement plans in this switch. Can speakers address how sick elderly seniors can switch to Medicare supplement plans?
Yeah, I mean, it's pretty limited, your availability to get into a Medigap plan after, if you've been in MA for more than the 12-month trial period, and you're not in one of the, just a couple of states that has continuous or some other kind of enrollment period. Generally, you can't get into a Medigap plan without underwriting. So your health conditions can be used and can have very high premiums, or you could just be denied outright. So yes, while I know a lot of sicker, older individuals do prefer traditional Medicare and would like to switch, it's my understanding that a lot of them are quite stuck in their MA plan and can maybe switch to another MA plan that might have a better network or something, but generally have a lot of trouble getting into traditional Medicare no matter how much they would like to switch. It's just cost prohibitive without a Medigap plan, and they have very limited access to a Medigap plan.
Thank you very much, Akata. Chris says, excellent presentations as always. Thank you. And asks, how vulnerable do you think the expanded coverage of PrEP for HIV prevention, now free under Part B, might be given the new administration?
Kata,
Yeah,
is that part of the Braidwood litigation?
I think it was, wasn't it? I believe it was. I'd have to look. I don't have a specific answer on that one. I haven't heard that on any kind of list of targeted changes specifically. That does not mean that it wouldn't be something that would be targeted, but I haven't actually seen that or heard that mentioned anywhere.
Well, I mean, one thing I will say in general, and because I think that, and this sort of goes along with what Toby was saying too, and because that coverage of preventive services was also the subject of litigation, and it's something that I can talk about now that we have a little bit of time also was the fate of the Medicare prescription drug price negotiation cases, also the subject of litigation. The incoming, I think for any of these topics, whether it's the nursing home staffing or coverage of preventive services, including PrEP, or the prescription drug price negotiation program, we just don't know what the fate of that of those topics are going to be. I can say that for the prescription drug price negotiation, the incoming administration may take a different approach. There's over half a dozen cases that were filed by the drug companies and their allies that were trying to stop that, the first ever program in allowing Medicare to use its negotiating power to bargain for lower drug prices. They've mostly not been faring very well in the courts so far, and we at the center have joined amicus briefs supporting the government in defending that negotiation program, but the incoming administration may take a different approach. It may not support the program, or it may not support it as enthusiastically. We just don't know. We also don't know exactly what it will try to do with the Inflation Reduction Act. If it tries to repeal it wholesale, that would be the end of the negotiation program, but it could try to do something piecemeal that would keep the program or maybe modify it or slow it down. And that could even spawn additional litigation. So, you know, we just have to keep our eyes on it. You know, that was a long-awaited victory for beneficiaries to get that negotiation passed, and, you know, we'll continue to support it. And I think the same goes for the preventive services as well. Yeah, we were amicus, I believe, in the Braidwood litigation as well, which was about the preventive services, and we'll continue to support that. That was part of the ACA requirements, if I remember right. Am I getting that right, Kata?
Yes, yes,
Yeah.
yes.
Thank you both. If there's no follow-up on that one, Kelly Jo from Minnesota, SHIP and SMP director out there, says we are in a crisis situation where many of our large providers are refusing to bill certain MA plans beginning in January of 2025. As a result, we're experiencing a tremendous increase in call volume requests for people who want to change plans. Are we aware of any other states experiencing this, or is anybody on the call aware that their state is experiencing this? This actually is tied in with the question Mark originally asked about providers dropping out of MA networks.
Yeah, I mean, we've read a lot of reports about this happening. I don't think we have heard about it from specific, you know, SHIP programs. So if anyone else on the call has seen this or heard about it, please feel free to speak up. But yeah, this is the trend that we're seeing. Part of what's been receiving a lot of media coverage is when this kind of thing happens. It's gotten a lot of press.
Our
Thank you.
colleague Christine Huberty just said it's happening in Wisconsin as well.
Thank you, Christine.
I think there's been a lot of advertising to the public from CMS saying, need to look at your plan because there are a lot of changes this year. You know, they're not exactly saying what they are, but trying to advise people that they need to pay attention and not just automatically sign up for what the plan they had before, which most people do.
Joyce from Illinois notes that Illinois has had enough of Advantage programs. I'll get calls from the agent who sold them the Advantage program asking me to help them appeal something they were denied for.
Yeah, I mean, this is a big problem, and we, as I said before, we have been seeing a lot more media coverage, a lot more congressional interest. So things sort of seemed like they were headed in the right direction over the last few months, at least. There was an interest in trying to figure out how to achieve parity and rein in overpayments, maybe have an out-of-pocket limit in traditional Medicare, which is sort of like the big ask that creates all these issues with Medigap plan, the need for Medigap plans as well. But all of that, you know, is in question now. So I can't really predict exactly what will happen with this and whether there still is an appetite. I think it is important to note that in Congress, their majority, even though they do have it in the House and the Senate, are very small. So they will need to work across the aisle to get things done. And maybe some of our biggest concerns and fears around Medicare and Medicaid and the ACA will be more difficult just because they don't have such a big majority. They are really slim. So we have to continue pushing for these reforms while also addressing the defensive work that will come from the attacks whenever they are, you know, made public.
Yeah. Janet, did you have more to add on this?
Yeah, I mean, this is certainly happening in California. I know it did last year in San Diego in a huge way with the Scripps Medical Group and Hospital not contracting with any MA plans. And now it's happening in the Bay Area. Specifically, I'm from Alameda County with the SHIP program in California. And we're experiencing a lot of confusion and distress from Medicare beneficiaries who have established relationships with Sutter Health and Stanford Medicine and doctors. And There are no MA plans next year that are contracting with either of those two large medical groups. And several of them that did contract this year are leaving altogether. So we're being fairly inundated with calls from really upset Medicare beneficiaries whose choice is to really return to original Medicare and get a Medigap policy if they can afford one. They do have a guarantee issue right to get a Medigap because their plan is leaving or their medical group is no longer contracting. That's good. But again, if they can afford one, that's the only answer for them in order to continue seeing their doctors. Otherwise, they change doctors in the middle of treatment, et cetera, et cetera. And I will add and end by saying that it is really hard to figure out prior to, of course, and during the open enrollment period, which plans will be contracting with which medical groups. People are getting letters saying their plan is leaving. They want to know which other plans are contracting. Plan websites are not necessarily up to date. The provider search engines I'm talking about specifically. And the medical group websites themselves are not up to date. And the CSRs cannot answer questions. And they tell people they give people, like in Stanford's, the case with Stanford, an EMPI number, a national provider ID number, and say, call the plans and find out if your doctor's contracting with this number. People are not able to do that. And there's no other information out there that's clear and up to date as to which plans they are contracting with. Huge problem.
Huge problem.
And it appears that CMS has no control over this sublayer of the Medicare Advantage plan contracts.
That's right. And I think when they do have oversight, we've been disappointed in the level of oversight that they are actually using.
Yep. Susan backs that up in Alabama and is very worried about people who don't look into their coverage, which I know. All we can suggest every year is please check, even if you were happy last year.
Right. I'd like to ask a question for those who are working on enrollment issues, whether you are seeing the same drive of the flex cards. Like we've seen in the past that it's really a huge driver of enrollment, like people coming in saying, I just want flex, I want the plan with the highest flex card amount. Is that what people are still seeing? Yeah, sorry, go ahead.
Especially for DSNPs, right?
Right.
Yes, dual special needs plans, right?
Yep.
We're hearing that as well.
Yeah, that's a real problem with what we've seen with the public benefits being jeopardized. So please keep us informed if you hear of that happening or if you want to join any future advocacy meetings. We're hoping that we can get that resolved. That seems like it might be something that we could do in the next administration because the industry supports it as well.
I'm also concerned about ISNPs, the institutional special needs plans. They're much, much smaller than DSNPs, but some of them are being started by nursing homes directly so that they control the Medicare coverage of their residents. It's for people who are in the nursing home expected over 90 days or some large number of days. So it's really not the Medicare anymore, but it's not their Medicare coverage for skilled nursing facility, but for other things. And it's been a problem where we've seen that. So if anybody has any experience with that, I'd be really interested in hearing from you. ISNPs.
Yep. And Rachel, who was on briefly to verify that JIA was also familiar with that issue, wanted to also clarify that choices during enrollment are different for the dually eligible folks because Medicaid covers a lot of services that would fall under Medigap otherwise. So they don't necessarily have to navigate what other folks do.
Yeah, for that issue where your provider is no longer enrolled in the Medicare Advantage plan, acknowledging this is a huge problem for many people on Medicare. It may be a perceived problem for people on Medicaid that they can't go back to traditional Medicare, but for dually enrolled folks in Medicaid and Medicare, it's much easier to go back because their Medicaid coverage will cover many of the things that Medigap would have.
Thanks, Rachel.
Thank you for pointing that out, Rachel. A really important point. Yeah.
And Kelly Jo says in Minnesota, yes, definitely seeing the flex card issue, even though their benefits aren't even as generous as other states. All right. Any final comments as we run up against our hour here?
I think we should just mention that our next call is right now slated to be in January, and we'll send out more information when we finalize that date. But we look forward to continuing all of these conversations with all of you and to amplify your work and reach out to us as these attacks that we are expecting come to fruition coming months.
All right. Thank you very much, Kata. Thank you to all of our presenters today, and thank you to everybody who attended today's National Medicare Advocates Alliance call for your great participation. Love that. As Kata noted, be on the lookout for the invitation to our 21st 2025 Alliance call, which will be sometime in January. Thank you all again, and I will end today's presentation now.